Thank you for the opportunity to present. I'm presenting on behalf of the Hermes collaborators. Do I just click the mouse?
The next.
Okay, gotcha. So I have no relevant disclosures. So as we've heard throughout this meeting, the optimal imaging paradigm for neurothrombectomy selection is of great interest. And in the early time window and late time window, there may be different paradigms that may be relevant. And the purpose of this talk, I'm going to be focusing on the early time window, where there still remains some debate as to what is the ideal imaging paradigm. The way you can think about this problem is that you can take an approach that involves very rigorous screening with advanced imaging, such as MRI or CT perfusion, or you can take a more simplified screening paradigm. And there's advantages and disadvantages to the two approaches. If you're very rigorous with your screening, you need more patients to screen. The number you need to treat will be lower. The workflow is slower as you add imaging steps to your paradigm. While you scan patients, you are growing the core. This is something we have to accept, that every minute we delay by trying to evaluate the patient, we are creating harm by imaging that patient. So how much does that core grow while you image them? There's availability of advanced imaging that may be limited in various resources. This may be the case in a place that's a very busy ER where you may not have availability. At our center, traumas take precedence. So getting even access to a CT scanner can be a challenge. And then there's, of course, the denominator fallacy. That is that when you use advanced imaging, you're excluding a lot of patients that are not being treated, and we don't account for those when we report out outcomes. On the flip side, with the simplified screening paradigm, there's less number of patients to screen, a higher number is needed to treat to show benefit, but the workflow is faster. Are there rates of harm if we over-triage? That is, are we hurting patients if we treat too many patients, perhaps with a large core? What is the availability of the neuroangio suite in your environment? And then is there eventually a ceiling effect at which we don't see benefit? So to look at this question, in the Hermes data set, we aim to look at a simplified paradigm, that is CT alone, versus advanced imaging with perfusion imaging, to understand the safety and efficacy endpoints. So the Hermes consortium was a meta-analysis of individual patient-level data. This was from the randomized controlled trials that compared thrombectomy to medical management in the anterior circulation for predominantly ICA and M1 occlusions. In this analysis, we looked at 5 of the trials. And for the data that was available, we had a total of 1,336 patients. And the split was pretty even in which patients got CT only or CT-CTA. That was 733 patients. And then 603 patients that got CT perfusion imaging. In this study, we looked at primary efficacy endpoint as MRS 0 to 2 at 90 days. And then the safety endpoints were symptomatic hemorrhage, pH2 at within 5 days, and then mortality at 90 days. This slide illustrates the baseline characteristics in the two populations, and in this slide you can see that the characteristics are fairly comparable between the two groups. Average age about 65 to 66, NIH of 17. Aspect was slightly numerically higher in the CT group, but this is not statistically significant. There's a pretty even distribution of the location of occlusions. About 27-28% were IC occlusions, majority were M1 occlusions. You can see most of these patients are treated around 4 hours from onset to puncture. The onset to puncture as well, just to point out, was about 253.9 minutes in the CT-only arm, and the CT perfusion arm, 245.3 minutes. Not statistically significant. If you look at the clinical outcomes, again, our primary interest was in MRS 0 to 2 at 90 days. We found that in the CT head triage group, good outcomes in the thrombectomy arm were 44.1% versus 27.3% in the control arm, so clearly a benefit with thrombectomy, as we know. If we compare those numbers in the CT perfusion group, you can see that the good outcomes are comparable for thrombectomy, 46% versus 28.9% in the control arm. So really no difference in outcomes based on which imaging paradigm was used prior to treatment. In terms of safety profile, there was comparable rates of mortality across all 4 groups. And similarly with symptomatic hemorrhage, there's about 3 to 4% symptomatic hemorrhage rates, which are again not statistically significant. This is the Grata bars for these patient population, and you can see again, this is the same data I just showed you in a different format, showing you that with CT perfusion as the imaging paradigm versus CT only, there's no difference in outcomes in terms of MRS 0 to 2 at 90 days. So in conclusion, whether in the Hermes data set, the CT only or CTP paradigm were used, there's no significant difference in workflow. If you look at primary efficacy endpoints, in both groups, thrombectomy was superior. And again, the differences between the 2 groups, 46 versus 29%, or 45 versus 28% were essentially identical. There was no differences in the safety endpoints of symptomatic hemorrhage or mortality in the 2 groups. And so our data would suggest that CTP may not be required for patient selection within 6 hours of onset. That's my last slide.
Thank you so much. Dr. Jadaf would stay for another talk on first pass effect in the anterior and posterior circulation insights from the TRIVO registry. Yeah, it will automatically load.
Right. Thank you for the opportunity to present our data from the TRIVO registry. So the TRIVO registry was 2,002 patients that were treated with the TRIVO device. This will be focusing on the first pass effect in the anterior and posterior circulation. So as a means of background, achieving revascularization of TICI2C3 after a single pass has been defined as the first pass effect in a paper by Zaidat with the NASA registry, and this has been associated with significantly higher rates of good clinical outcomes. That study looked predominantly at the solitaire device. We aim to characterize the clinical features and outcomes in patients who achieved FPE in the TRIVO registry. So just as a reminder, TRIVO registry was a prospective registry, single arm, looking at the TRIVO device 0 to 24 hours in anterior and posterior circulation. This study enrolled ICA M1 and M2 lesions as well as basilar lesions, and we analyzed in situations where we had access to a number of passes and recanalization. So we had 1357 patients in the anterior circulation and 78 in the posterior circulation. Our first pass effect was the similar definition as what was used in the NASA registry, so it's a single device pass with the final recanalization of 3 or 2C with the first pass. And then the safety and efficacy endpoints, 90-day MRS 0 to 2, symptomatic hemorrhage at 48 hours, or mortality at 90 days. The predictors we tested for in this registry were both patient-centric as well as procedure-centric. So we looked at age, gender, cerebrovascular risk factors, stroke characteristics, that is baseline NIH, site of occlusion, as well as the quality of collaterals and aspects. In terms of procedural characteristics, we looked at time lasting well to groin puncture and the use of balloon guide catheter, as that's been implicated in the past as a predictor of FPE. Statistical analysis was performed between the FPE, non-FPE groups, as well as in groups that received final recanalization of TICI2B or TICI2C with multiple passes. So I'll talk about the anterior circulation data first. So this was, again, patients who had thrombectomy for ICA, M1, or M2 occlusion. This was 1,357 patients, and you can see that the first pass effect was 27.9%. Of the patients who did not undergo first pass effect, 18.1% did have a final recanalization of TICI2C3. This is kind of a busy slide, but it's just to look at some of the univariate comparisons between the FPE versus non-FPE group. But you can see that there are some slight differences in the groups. For example, the FPE group was slightly older This was statistically significant. There's a high rate of atrial fibrillation. The baseline core size as measured by aspects was slightly better with aspect of 8. There were more M2 site of occlusions in the first pass effect group. There was higher utilization of the balloon guide catheter, but again, this was non-randomized, so this is just proceduralist preference. And there was a higher rate of good collaterals, 83.9% versus 76.8% in the FPE group. In terms of the efficacy and safety endpoints, there was higher rates of good outcomes in the FPE group, 63.9% versus 53.5%, with no significant differences in the safety endpoints. We were interested in looking at whether the first pass effect simply just captured patients who had good recanalization, so we compared the patients who had first pass effect versus those who did not have first pass effect but did achieve TICI 2C3 as a final recanalization against the patients who did not get TICI 3 or 2C and had less than 2C recanalization. And what you can see is that the benefit of the first pass effect does persist. That is, the good outcomes were 63.9% in the first pass effect group, whereas the good outcomes were 57.6% in the group that did achieve TICI 2C3 recanalization with multiple passes. If you look at the emboli in distal territory, you can see that that is higher in the group that had no first pass effect but did eventually achieve TICI 2C3 recanalization. And you can see that's even higher in the group that did not achieve TICI 3 or 2C recanalization. Again, the safety endpoints were comparable between the three groups. If we look at multivariate predictors of FPE, the predictors that we identified were both patient-specific, that is atrial fibrillation, baseline aspects, and site of occlusion. So non-IC occlusion was associated with first pass effect. I'm going to transition very briefly to the posterior circulation, where there's actually very little understanding at present about what are predictors of first pass effect. And we did some analysis. Bear in mind, these are very small sample size, so we only had 78 patients for analysis from the TRIVO registry. The only significant predictor we identified for the first pass effect was gender. So there was a higher percentage of males versus females that achieved basilar artery occlusion first pass effect. And then there was really no consistent differences in the safety endpoints or the primary efficacy endpoints. So this may be limited by our sample size. So in summary, with the TRIVO device, the first pass effect is associated with greater likelihood of good outcome as defined by MRS 0 to 2 at 90 days, and there is a reduced likelihood of emboli in distal territory in those patients. The predictors of first pass effect are both patient level, that is non-IC occlusion, good collaterals, favorable aspects, interestingly older age in this data set at least, as well as atrial fibrillation. And then again, as other analyses of first pass effect that we've seen with NASA, with the Stratus registry looking at solitaire, with the ARISE 2 data looking at the EmboTrap device, the balloon guide catheter does appear to be a consistent association with the first pass effect. So in conclusion, the first pass effect may be a good early surrogate for clinical outcomes and may become a relevant early biomarker of device efficacy. But there are factors that are both patient and procedural specific that are relevant to the discussion. And we really need to focus further research on improving first pass effect for the ICA location, as this appears to be a risk factor for non-FPE. And posterior circulation FPE is very poorly understood and requires larger data sets. Thank you.